Okay. All right, good afternoon. As Heather said, my name is Kelly Chase, and I'm the Chief Privacy Officer for Horizon Health Network. I've been with Horizon since 2016, but prior to that, I was with VasilaCorp and with Service New Brunswick in the same capacity. So I've been doing privacy and healthcare work since about 2008. In terms of work background, prior to that, I practiced law for 15 years, and in between, I taught kindergarten for 4 years. So that's my background. We only have an hour, which is actually not a lot of time for a presentation. So I put together a PowerPoint, but I'm really flexible in terms of, going down a different path. So we'll start with this, and if we wind up having questions that take us down a different route, we'll forget about the PowerPoint. So what I like to start with generally is just a sort of description of what privacy is, because oftentimes people confuse confidentiality and privacy. So privacy is an individual's legal right, and it's actually also a human right, to have some control over what information about them is shared with others or who can access it. So basically, I have a right as an individual to decide who gets to see and use my stuff, my information. And so when we're thinking about privacy, we oftentimes have to think about what would be contemplated by the individual in terms of sharing information. And if you're sharing information or accessing information and you say to yourself, the patient probably wouldn't have any reasonable idea that I'm in here or sharing this, that would give you a strong indication that there's a privacy implication. So we have a privacy law. I carry it around. We call it FIPPA. It's the Personal Health Information Privacy and Access Act, and that came into effect in 2010. We had a privacy commissioner, and that's now gone, and then we had a privacy integrity commissioner, and that's now gone, and more recently the Ombudsman's office took over the control of this legislation. The purpose of this act, some of you might remember from years ago, we had an act called PAPAIA, which was about a 3 or 4 page piece of legislation that basically highlighted 10 privacy principles. And this is before we all became Horizon, and there were 8, I think, different health authorities. And the problem with that legislation was that everybody was interpreting it in their own way, and that resulted in sometimes policies being quite different around accessing personal health information, the use and disclosure. And so this legislation is far more comprehensive, and really provides clearer guidelines on what can be shared and accessed and disclosed. It creates all kinds of rules about the collection, use, and disclosure, retention, and secure destruction of health information. It's meant to ensure accountability on the part of people who have access to PHI in their work. It has a section around the safeguards and security of personal health information and what our liabilities and responsibilities are in terms of making sure we keep that information secure. It gives individuals a legal right to access their own health information. So as a patient, if I would like to have a copy of my records, I'm entitled to that. The chart belongs to Horizon Healthcare, but the information in that chart belongs to the patient. It's my information as a patient. And it also allows individuals to make requests to have corrections made to their chart if there's a mistake made. So what is personal health information? It's identifying information about an individual, and it can be in oral or recorded form. And I've sort of highlighted identifying in red, and we'll talk a bit more about that. But there's a lot of confusion sometimes around what is and what is not identifying. Some people are under the impression that, for example, if you don't say a patient's name, you're good to go. But if information can be linked with other information and you can figure out who it is, it's considered to be identifying information. So we'll talk a bit more about that. So basically, it's person's physical, mental health, their family history, their healthcare history, any genetic information, your registration information is your health information, your Medicare number. Even my family doctor's name in the context of my healthcare is my personal health information. Payments, eligibility for healthcare, donation of body parts, bodily substances, blood work, all of that kind of thing is all personal health information. Who my substitute decision maker is, that's my health information. And again, my doctor's name even is my personal health information in the context of my care. So identifying information is any information at all that would identify the individual or which is reasonably foreseeable if it was linked with something else would identify the person. So you have to be really careful. We've had a number of breaches in Horizon where information has been shared believing that it's not identified information and it has been a breach. We had a physician, for example, in one area who was posting pictures. He was a surgeon posting pictures on Instagram. And one of them was, it's not so much the picture that was identifiable because it was somebody's colon. That's what he put up on Instagram. But he also added to that post from my clinic today. So all of a sudden, you know what doctor it is. You know that he's, I'll say St. John. It wasn't St. John. So you know what doctor it is. You know he practices in St. John. His clinic that day had 4 patients. So right away, you're down to 4 people. So even though we didn't name the patient, there were people that knew exactly what patient that was. So it was identifiable information and it was a breach. And we have to be careful with photographs because, you know, you think one colon looks like another colon. But the fact is, going back to my definition of personal health information and going back to the idea that it's my right to decide who gets to see my information, it's not reasonably contemplated by me when I go in to have, you know, a procedure done to my colon that my picture is going to wind up on Instagram. Right? So you have to think about what would the patient reasonably contemplate is going to happen with their information. And most people, without being told by the surgeon that they're going to share it in that way, would not contemplate that that's part of their care or that that would be shared. So why is privacy in healthcare important? Well, obviously, patient information is one of the most sensitive types of information there is. In terms of hacking and dollar value, it's stated now that health information is the most valuable form of information, even more so than financial information. So it's used for fraud and identity theft and for all kinds of illegal purposes. We want our patients to feel comfortable when they come, to the hospital, that whatever information they share is going to be kept confidential and private. If they don't have that confidence that their information is going to be kept secure and private, sometimes that leads to them not sharing information that should be shared for their care. Some people have a very sensitive health history. Maybe they've had a rape in their background, they've had sexually transmitted diseases, they've had any number of things that people might find to be embarrassing. They might not disclose that to a healthcare provider, and it might be very relevant to their care if they think that that information is going to be kept private. So again, our patients provide us with personal and sensitive information, and it's a privilege for us to have this information. This information that we have access to is based on our role. We have role-based access in Horizon. So the purpose of giving you access to health information is to enable you to do your work and to do your work only. You should only access information that you need to access to do your work, and that's called the rule of minimums. So that means that you only access what you need to do your work and you don't go diving around or looking at things that you don't need to do your work. Let's see here. So we'll talk just generally about consent. So that's really the basis of this legislation really is consent. And what it talks about is the fact that a person has to consent to the collection of their information and the subsequent use and disclosure of the information. And for consent to be valid, it requires that the individual be capable of consenting. So they need to understand what they're consenting to. They need to have capacity to consent. And if they don't, their substitute decision maker would be the one to provide consent. The consent needs to be knowledgeable, so they need to understand what is the purpose of you collecting their information. They need to understand why you need it. When somebody comes in to emerge, they're asked all kinds of questions, and if they were to say, why do you need this? The response would be, we need all of this information in order to provide care to you. You're getting a health history, you're collecting their Medicare number, you're collecting other information from them that's relevant to their care. So a person can withdraw their consent if they change their mind. They can refuse to consent in the first place. You can't obtain consent through deception or coercion. They need to understand and it needs to be knowledgeable consent. It can be expressed or implied. And the general rule is that a consent, if you have an express consent, it's valid for 1 year and then it needs to be renewed. So express consent is explicit consent. The person has said yes to the purpose. Yes, I consent to you taking my blood. Yes, I consent to you sharing my information with Dr. Smith. That's an express consent. And it doesn't have to be in writing anymore. It used to be that express consent needed to be written. Now the legislation has been changed and it does allow express consent to be given orally. But the condition is that if you accept an oral consent, you have to document that in the chart. So it does have to be documented somewhere. Express consent is the strongest form of consent. And again, it does need to be documented. So implied consent, we rely quite often in the healthcare system, we rely quite often on implied consent. And that's consent that's not expressly granted, but it's implicitly granted by a person's actions or the facts and circumstances of the situation. So when I do go to the clinic F to give blood, they don't ask me down there if I consent to have my blood drawn. It's implied that I'm there. I've come with my requisition. I roll up my sleeve and I hand them my arm. They have my implied consent to draw my blood. We provide treatment to unconscious patients when someone comes to hospital via ambulance and they need immediate treatment. We go ahead and we rely on implied consent to treat them. And the last one, and we'll talk a bit more about that, is continuity of care, which is Section 18, subsection 1 in FIPA, which allows us to rely on a patient's implied consent for continuity of care purposes. So that would be one healthcare provider having conversations with another healthcare provider who's involved in their care about the patient. We don't go back to the patient every time we do that and get a consent from them. So Section 18.1 kind of leads into a discussion about circle of care, and I've put this in here and I've been reluctant to put it in because I don't like the term circle of care. And the reason I don't like it is because it's not defined in the legislation anywhere, but I have found over the last 10 years that it is a term that's used, and healthcare providers will use that term very often. So just to be clear about what that is, it's a group of healthcare providers who are treating the patient and need information to provide care to the patient. You can rely on a patient's implied consent when collecting, using, or disclosing information to provide care to a patient. So a patient who accepts a referral to another healthcare provider, for example, is giving their implied consent for sharing of relevant information between those two healthcare providers. Healthcare circle of care would not include custodians who are not part of a direct or follow-up treatment of an individual, non-healthcare information custodians, so as an example, insurance companies, they would not be in the circle of care, even though they very often ask for health information. And family, friends, the police, they are not part of the circle of care. So it has to be people that are currently treating the patient or someone who the patient is aware of that you've referred them to. So one of the other principles in the legislation is accountability, and it says that as custodians, and we are all custodians, anybody that is involved in the care of the patient is a custodian of health information. We're all accountable for protecting privacy and maintaining confidentiality of personal health information, and we can't delegate that responsibility to anyone else. So 3 quick general privacy rules. The first is to obtain consent from individuals to whom the information belongs. You will only collect or use or disclose the minimum amount of information necessary for the purpose, and you should only share or handle information on a need-to-know basis. Just a quick review of a couple of policies, and then I'd really like to open it up to questions, because I think there were some questions that you had in pharmacy that I'd like to be able to address for you. The confidentiality policy establishes obligations for the handling information. This is something that's mandatory to be reviewed on an annual basis, and there's a confidentiality declaration of understanding that you're asked to sign every year. That promotes compliance of employees, and it sends a clear top-down message that privacy is vital to the organization. It fosters a culture of privacy through top-of-mind awareness. That's why we ask for it to be signed on an annual basis. And that confidentiality declaration delves a little bit deeper. It's not just personal health information, it's also sensitive corporate, private information, confidential information. It also includes having discussions about other employees and that sort of thing. So it's a little bit broader than just health information. We also have a privacy incident and breach management policy that you should be aware of. That policy outlines all of the procedures that need to be followed if you think that there's been a breach or there's been a privacy incident. It highlights my responsibilities as well as the responsibilities of employees and managers around notification and around containment of the breach. Anytime we have a privacy breach, there's a legal obligation for the individual who's had their privacy breached to be notified and told that their information was breached. And I also have a legal obligation to report the breach to the Ombuds office. This policy also identifies levels of privacy breaches, and it assesses culpability and risk. It identifies preventive measures and follow-up actions and corrective actions. So what happens when there's a privacy breach? Generally, we have what we call a fact-finding meeting with the employee who's been if they've been accused of a breach, for example. And that's an opportunity for the employee to explain their side of what happened, why they accessed or why they disclosed or whatever the case may be. That generally comes back to me if I'm not part of that meeting. Oftentimes managers conduct those meetings. And then I have to look at the situation to determine, first of all, has there been a breach? And if there has been a breach, what is the level of the breach? The policy outlines 4 different levels of breaches, 1, 2, 3, 4. A level 1 breach would be an innocent human error. So it could be a huge breach. It may have a huge impact on the patient, but it wasn't a deliberate breach. It would be like somebody putting in the wrong fax number by mistake. And that has happened. It happens every single day in Horizon that faxes are misdirected, emails are misdirected, mail is misdirected, either that it's not been addressed properly or a number's been inputted the wrong way. So, like I say, it can result in a huge breach. But when I look at that, the level of culpability of the employee, and that's the blameworthiness of the employee, anybody can make an innocent human mistake. And so their culpability for that would be low. The risk, when I do a risk assessment, I look at the risk to the patient and also the risk to Horizon arising from the breach. And together, all of those things help me determine if it's a level 1, 2, 3, or 4 breach. A level 4 breach would be a very serious breach, usually with malicious intent. We've had breaches, for example, where an employee, well, one in particular that we had, an employee was dating someone who was in the middle of a fairly nasty divorce where custody was an issue. And this individual was looking up her boyfriend's ex-wife to basically see if she could find any dirt that he could use in the custody battle. She found some good stuff, methadone clinic and other things, and took screenshots of that and texted it to her boyfriend. And anyway, that was malicious, and it was a level 4 breach, and she was dismissed. So that's an example of a level 4 breach. Many breaches. This week already, it's only Tuesday, I've done 2 privacy breach evaluations so far this week that have popped out as a level 3. Many breaches wind up being a level 3 breach, and those are usually where somebody has inappropriately accessed information, not for malicious reasons, but they've gone into records that they didn't have a work-related reason to go into, and those are generally a level 3 breach. And those they can result in dismissal, but more often they result in a suspension. And some of those suspensions are pretty hefty. I know that if I didn't get paid for a couple of weeks, I'd feel it. So anyway, those happen more often than I'd care to admit, but and they happen for different reasons. The ones this week, we had one person looking up a family member. They weren't involved in their care, but they were looking something up out of concern. But again, they weren't part of the patient's care, and they should not have gone into the health record. In that case, they also made a disclosure of information, and that wasn't appropriate, and that was a level 3 breach. The other one that we had, it was also a case of concern because a family member was reported missing, and they went into the health record to see if they had any recent medical appointments or, trying to figure out what might have happened to their relative. But again, they weren't involved in the care of the patient. They should not have gone into the health record. And that was also a level 3 breach. And so I don't know what the discipline is on those right now, but it's highly likely that it'll be at least a 5-day suspension without pay for something like that. So you really want to be careful about accessing information that you don't need to access in order to do your work. This one, a lot of people don't know exists, but it's really helpful. It's the confidential information sharing policy, and it's a bit of a funny policy because it's more of a guidance document. So that policy would give you tips on how to share information properly. So, whether it's leaving phone messages on a patient's phone, sending faxes, emails, texting. People have a lot of questions about that stuff, and a lot of that is addressed in this policy. Whether or not you should use internal mail service or if you should use Canada Post, carrying information from one location to another. All of those things are addressed in the confidential information sharing policy and how you should go about sharing that information. So these are just some of the challenges, because people sometimes find this interesting, but and actually, honestly, I just took this slide and changed it from 2019 to 2020 because they don't really change. But we have a lot of breaches arising from posts on Facebook and social media, you can imagine, and it's people have to be really careful. Again, we talked about the doctor posting images of things that on the face of them look like they were de-identified, but a lot of people are getting themselves into trouble with this kind of thing. So what's another good example? We had a student nurse, this is a few years ago, so she wasn't a Horizon employee, but we had her working in a Horizon facility as a student. She had signed the confidentiality declaration of understanding. She had taken her training. And again, it's Instagram. I don't know what it is with Instagram, but she basically took a picture of a patient chart and she thought it was blurry. And then she shared it on Instagram and she put a couple of emojis on. She did an eye roll emoji and I think a happy face. And then she put a caption on it, something to the effect like a day in the life of a nursing student or something. So it was really innocent. It wasn't a malicious thing. But it turned out on Instagram, the chart was not as blurry as she thought. So it had the patient name. So we knew what hospital. It had the patient name, his age, his doctor. I think the reason for the eye roll emoji, it was for a fleet enema. So there was information on there, and this was an elderly patient, and his daughters, there were 5 of them, were fit to be tied when they saw this on Instagram. They were really, really upset. This resulted in working together with the community college, and initially they gave her a 3-day suspension from her classes, but it was increased to a 5-day suspension. And what that meant for her was that she failed a mandatory course, and she couldn't take anything else. Basically, it held her up for a year. She had to wait until the next year to take the courses that she needed. So I'm sure in hindsight, she's wondering what she was thinking when she decided to post that on Instagram. But this happens quite a bit. We had another one. Where somebody posted, it wasn't about the patient, but it identified the patient. They had a bit of a run-in with the patient's daughter. It was an elderly patient once again, and she posted a snide comment on Facebook. But because of the information she shared on Facebook, it was possible to figure out who the patient was. Because again, we've showed up in Emerge at 9 a.m. It's an elderly patient. They arrived by ambulance, and that they were sent back to such and such nursing home. So, there were people that actually called this woman and said, just saw something on Facebook and I think it's about you. So that's identifiable. She didn't name the woman. She didn't name the patient either, but people knew exactly who they were talking about. So that was another one. What else? Photographs on cell phones, that's a problem. We've had, people forget, physicians are guilty of this quite often because physicians will take pictures. And, you can imagine on your personal cell phone, for one thing, they're not all password protected. They're not all encrypted. And it's Saturday afternoon and you're showing a friend of yours pictures of your son's birthday party. And the next thing you know, as you're scrolling through your pictures, you've got a patient in the middle of all that. So it's really quite risky to be doing anything on a personal device. I can't tell you the number of breaches that we have still, even with all the privacy training we have in place. Around curiosity and snooping. People will look stuff up because they can't help themselves. And I have no control over people deciding to do the wrong thing, but I do caution you that we do random audits. We had the missing person that I talked to you about, that the person accessed the chart because they were concerned because there was a missing family member. As it turned out, that family member wound up dying. And so I said, let's do a random audit. And we just did the audit yesterday. We've already found 3 people that have gone in out of curiosity to find out how this person died, what happened. I had to send out letters to 103 managers after the Fredericton shootings. We had a number of staff access the shooter, access the 2 deceased police officers, access the 2 civilians, because people want to know. So anyway, it happens quite a bit, and please be careful with mail and emails and faxes. We have so many things happen every day where we have misdirected emails. In particular, I've gotten into the habit now that when I'm sending an email, I fill in the top part after I'm done the body. I don't fill in the to line until I'm done because that way you can make sure you've got the right person. In Outlook, there might be 2 Kelly Chases and you put the wrong one in. We've had breaches where very sensitive information, somebody's pushed a wrong button and it's gone to a distribution list. So an email meant for one person, in one case, went out to over 300. So these are things that we have to be careful. And again, that might be a level 1 privacy breach. It might be an innocent human error, but the consequences for the patient who's had their privacy breached can be really, really serious. So I usually just end with this, and we've got lots of time. I kind of breeze through this really quickly, but basically you're responsible to respect the privacy of others. You need to handle all personal health information and personal information in accordance with the rules that are set out in the law. So I only spoke about the health legislation, but there's also our TIPA, the Right to Information and Protection of Privacy Act, and that's our second piece of privacy legislation that we have in New Brunswick. And that deals more with personal information as opposed to personal health information. You need to follow all of the security procedures in place within our organization to ensure that information is kept confidential and safe and secure. Report incidents and breaches to my office. Breaches should be reported right away because we need to contain them. Sometimes we've had breaches result from a technical glitch where for some odd reason faxes are spitting out on the wrong machine or something weird happens. So sometimes we have to shut down a system or we have to get IT involved right away to fix a technical glitch. Other times we want to make sure, like say that we've contained it. If a bunch of papers are blowing around in the parking lot, and that's happened before, we want to get somebody out there to help us gather them up as quickly as possible. When I was with Facilicorp, we had the back doors flew open on a van. They were picking up, for delivery, they were picking up lab samples, and a cooler fell out the back of the van and the top came off, and there were people's samples all along the highway in the ditch. And we acted on that very quickly and had a crew of people. It sounds funny, but like we could do a whole hour of me just telling you stories of things that happened, and I should write a book, but it's serious stuff, but it does happen. Crazy things happen. The latch was defective on the back of the van and out the stuff went. So, this can happen, but these need to be reported right away so that we can do the right things to contain them. And of course, when in doubt, ask. So the privacy service really just consists of myself as CPO, and Donna Nazalillo is our regional privacy consultant. And she's the one that does most of the work in terms of breach follow-up and work with managers when there's fact-finding meetings and that sort of thing. So that's really all I had in terms of PowerPoint. I think there were a few questions. A couple came my way that Heather had gathered up. I think, let's see. One of them had to do with pharmacy and hospital, sharing information with community pharmacy. So I think this had to do with clarification around medications and whether that was okay. So basically, as I said before, what would be reasonably contemplated by the patient is one of the questions that you ask yourself. And I think when it comes to sharing information with community pharmacies, if it's about dosage or there's questions around what the medication is or previous medications or what medications may conflict with others, that sort of thing is all in respect to continuity of care. So I don't see a privacy implication there unless I'm missing something with that question. But if the reason is for continuity of care purposes and for the care of the patient, there's not generally a problem with sharing information. What was one of the other ones? I don't know what the question was. I wrote down emailing and texting patients. So in your role in pharmacy, would it be often that you would text a patient? Is that something that happens, or?
So Kelly, it's Mike LeBlanc here in Moncton. So I would say there are situations where we do have patients communicating directly with pharmacy staff members, whether it's by email or texting. It's fairly rare. It's usually in the outpatient setting where you're following a patient longer term and you develop a different relationship with them.
Right.
And so they'll reach out to you directly as a question. I know I do in my practice. I have a work cell, so I will have texts that come directly to that from patients because they have that number, right?
Right.
So that's one scenario, and then the email as well. They'll have my card and they'll have my email address on it. So
Right. So there's problems around emailing and texting, and I've really struggled with it because when I talk to you about our policy, our confidential information sharing policy, it has some pretty strict rules around emailing and texting. And basically, when it comes to texting, the answer is you don't do it. But I know that people do it. And right now, all I can say about texting is that the only secure and approved texting that we have in Horizon is that microblogging, which has replaced pagers. Other than that, texting is not secure. Anywhere from 1 to 2% of texts don't actually arrive at their destination, and I can't tell you why because I'm not a technology or an IT person. But in consult with the DISOs in government, that's the Departmental Information Security Officers, that's what they've told us. So there's always a risk that you send a text and it doesn't get where it's supposed to. There's also risks, and these are not privacy risks, but I mean, there's also a risk around charting. I know there's concern around emails and texting because does information that should go in a chart not go in a chart and it's in an email somewhere? Texts don't get backed up like emails do. So you'd have to be really careful with that kind of thing. I've made some exceptions. What the policy says is that you can't text patients unless you have sort of authorization from me to do it. It would be an exception. And I have made exceptions, and I've made so many exceptions now that I don't even remember what I haven't kept good track of the exceptions I've made because most of them have been around appointment reminders. So in some areas in Horizon, they have equipment that can automatically generate a text or an appointment reminder. And I know in some cases that they've done those. I think physiotherapy, uses that technology where they can send an appointment reminder. We've said okay to that kind of thing because for one thing, I think it's set up so that the patient can't respond to the text. So basically they get a text, and I mean, I get them all the time. I get my nails done, I get a text, I get my dentist sends me a text. They never ask me for my consent. I had to fill out a form and said that this is my phone number, and suddenly I started getting texts. But really all they say is this is just a reminder of your appointment. And if that went to the wrong place, there's some information a person would know. They know that Kelly Chase has a dentist appointment on January 30th. But that's not overly sensitive. And if they know that you've got a physio appointment, that's not overly sensitive either. But I know some texting has happened, for example, in the ISD program, Integrated Service Delivery, with youth, because in some cases it's the only way to communicate with youth. If you can't text, you can't get anywhere. But we've really cautioned the use of texting there as well. If a youth texts a counselor, usually we'll say to the counselor, try to get them to call you. Text them back and say, I'm available, give me a call, and try to get them on the phone. You wouldn't want to be sharing a whole lot of health information via text. We've sort of taken a position for a while. I really struggled with this and said, if we're going to be emailing and texting, we've got to have a written consent from the patient. But that gets very complicated. And I told you with consents, they're only valid for a year. So then who's going to be accountable to chase around and try to get these consents updated? Where are we going to store them? And are they knowledgeable consents? Because then you get into the whole question around, for it really truly to be a knowledgeable consent, people would need to understand what the risks are of texting and emailing health information, and who is equipped on the Horizon side to explain those risks to people. We don't really have the ability to do it. So texting, I caution you on texting, and just try to keep it limited to the bare minimum, and keep in mind that if it's something that should be charted, that it does get charted. Emailing, our policy on emailing says that it's secure to send emails between what we've defined as a trusted network. So Horizon can send an email to Department of Health, Horizon can send one to Vitalite can send one to us. It's all in this sort of secure IT bubble where there's firewalls and different things where you can send emails and it's considered secure. So we do allow health information to be emailed. If I need to email health information to the Department of Health or vice versa, we can do that. We give some rules around in the subject line. You shouldn't put any health information in the subject line, and there's some rules like that. And on occasion, we've made exceptions where the email has been initiated by the patient, because to deal with this whole consent issue, I've sort of taken a position that if the email is initiated by the patient, that is their implied consent, that we can correspond that way. Whether that interpretation is right or wrong remains to be seen, and we may get a slap on the wrist, if there's a breach. But it's just, a lot of patients now are really demanding. They want to use email, so it's a real big challenge. But I'd be very careful. Like I say, personally, I would try to avoid it if I could. And again, just be very careful about what it is that you're saying in the email, because we have breaches every single day with emails going to the wrong place. And the thing about the secure network is that it is secure, but when you start emailing outside that secure network into Yahoo, Gmail, all of those are internet email addresses. And this is the place where the hackers and those folks that are up to no good, that's where they're going, and that's where they're getting in to get people's health information. And it doesn't take very much. I mean, a person's name, address, phone number, date of birth, Medicare number, those few little things are enough for identity theft and fraud. So you have to be really, really careful. Most patients wouldn't understand the risk, and most of them would say they don't care about the risk because it's convenient and they'd like to have their information emailed, but there are risks. So what else? There was another one. Presenting patient cases during learner rotations and consent. So I think, and we've talked about that a little bit. So that one's a bit tricky, because I think historically health information about patients has been shared for education purposes. There's been a recent wonky sort of edit to the law that does not. It allows us to share information without consent for education purposes to agents, but in the definition of agents, employees are specifically excluded from that definition. I don't know why they did that, but they did. So currently, there's no legal authority to share patient information without consent for education purposes. The other question you have to ask yourself, even if there was permission, is going back to that comment that I've made about, would this be reasonably contemplated by the patient? So as a general rule, like, patients don't all anticipate that you're going to use their information to educate other people. So when we talk about photographs, for example, there's a consent that should be signed. If you're using a photograph for clinical purposes, people may realize, when you take a picture of that burn on their leg, they might be okay with you taking a picture so that you can look at the picture a week later and see the changes and how it's healing and that sort of thing. But that doesn't mean the patient's okay with you putting it in a journal or using it in a paper or even sharing it with people outside that circle of care for education purposes. So with photographs, there's a consent now that gets signed that they're actually ticking off the box. I accept you using my picture for clinical purposes, and there's another one for education. So, for the most part, if you're doing rounds, and I don't know what your rounds look like when I think of rounds, and I'm not clinical, so I'm thinking Grey's Anatomy, and the doctor's got a group of 4 or 5 doctors tailing along behind, and they're going in to see a patient. Those students that are on rounds with a physician would be considered part of the circle of care, and you wouldn't need a patient consent for those residents or students to hear information about the patient or even to look it up. The rule of minimums would apply, so they're only going to be looking at what they need to do for the purpose, but they would be considered part of the patient's care in that context. I'm not sure exactly what the rounds look like with you guys. That was the word that was used, I think, when the question came my way, rotations. So what does that look like?
So for a student or a learner, they would be seeing a patient, assign a patient, and say, this is a case I want to present. So part of their learning is being able to present their thought process, how they identified the issues in that patient and how they intervened and helped the patient's care.
Right.
So it would be other students and staff, such as are assembled here, who have interest in supporting that student's learning and seeing what they've done. So they might review elements of that patient's case and what they did, as part of the team caring for that patient.
Right. Okay. So, I mean, strictly speaking, if they are introduced to the patient and they're part of the care, that is arguably okay. But we've had the conversation, Doug, about whether or not we need a consent. It's always best to get a consent. And the consent that you and I worked on, I don't know if that's been shared outside.
It's with our pharmacy residents right now.
Right.
They're
So,
trialing it.
what we've suggested, I mean, the easiest time to have this conversation with the patient, because there is some interaction, I'm assuming, with the patient at some point at the beginning. And just to say, and one of the things that I struggle with about that consent, having looked at it, is one of the first things it says is that it's de-identified. And we've had this whole conversation about whether something is identifiable or not. It goes on to say that we can't guarantee that it's de-identified, which is quite true, because again, when a student is talking about a patient, even if they don't use their name, it might be pretty easy for the group to know who the patient's talking about. So at the moment, unless and until they make a change to the legislation to allow for the disclosure of health information for education purposes, we're kind of stuck in this really weird gray zone at the moment about what we can do for education purposes. So if I'm advising on that, the advice that I have to give right now is that we would inform a patient that we're going to use their information. We'd be telling them, as you say in your consent, your name isn't going to be shared, but letting them know that there's a possibility that people will know who you're talking about. But it's in a small select group and it's for education. And in my experience so far in healthcare, I haven't run across too many situations that I've heard of where a patient isn't willing to cooperate with that and to share information for education. Most of them are. But the thing is that they do have the legal right to say, you know what, I'd really rather not, and they can say that if they want to. So, it gets complicated with consent. I run into a lot of frustrations on the part of physicians because really, even that whole section 18.1, that I love that section because that's that section that allows us to rely on implied consent. But what it says is that unless it's not reasonable in the circumstances to do so. And so what that means is that you can rely on implied consent, but if the patient has said, I don't want you sharing my information with Dr. Smith, you can't share the information with Doug Smith. And I know that this has caused a lot of trouble, in particular in the mental health world, because this seems to be where I'm getting a lot of calls from psychiatrists and whatnot. They have care teams, and you have a mental health patient who says, I don't want you discussing my case with anybody. And it really ties the hands of the care providers. And the only thing that we can do in that case, there's two things. One is when a patient does not allow us to disclose their information, but it's important information. So what's a good example? A patient may not want you to share with their family doctor that they've gone to the methadone clinic. Well, they have the right to say, I don't want this shared with my family doctor. But there's also risks associated with the family doctor not knowing that this person is taking methadone. So the law, all it does is it says if a patient gets a consent directive like that, you have to abide by the direction. But what you can do is you can reach out to the family doctor and you can say, your patient, you don't have the full picture. You're missing a piece of the puzzle. You can't tell them what it is, but you can tell them that much. You can say, your patient's given a consent directive. There's information that is important to their care, but they've instructed me not to share it with you. And the only value of that, at least the family physician realizes that there's something else and they can make decisions accordingly. When that patient comes in and is asking for certain medication, for example, the doctor might say, look, I know that you haven't been entirely forthright with me. This may compromise your care. I'm not prepared to prescribe this narcotic under the circumstances because I know that I don't have the full story. But it's a real challenge for healthcare providers that patients have the right to do that. The only other section that would allow us to get around that is Section 39 of FIPA, which is the section that allows us to make disclosures based on the fact that there's a reasonable and significant risk of harm. So that's the section that, if there is a serious risk of harm that is likely to occur to the patient or someone else, you can make a disclosure without consent. I've given a lot of guidance on that. It's not a might can sort of happen kind of thing. You have to be pretty sure that if you don't make this disclosure, something really bad is going to happen. It can't be a maybe sort of possible. You need to to be pretty darn sure that there's a real and significant risk of harm. So, for example, someone saying that they're going to kill themselves, you believe they have the means to do it. They've got they have a gun at home. You know that they're not doing well. You take their threat seriously. You can rely on Section 39. Trying to think of an example where we said you couldn't rely on it. Methadone clinic down the street in Fredericton asked the DEC, the Chalmers Hospital, if one of their patients showed up in Emerge and security needed to be called for any reason, methadone clinic wanted to know about it. And anyway, and I had to say no because they were making it on the grounds of Section 39, but that's not just because security gets called. If a methadone clinic patient goes to Emerge on a Saturday night, and I don't know, maybe they've had a drink or two, or maybe they're just frustrated and they start making a ruckus in the emergency room because it's taking too long and security has to come in and escort them out. There's no reasonable risk of harm to anyone. They wanted to know down at the clinic because they didn't have great security down there. And I think what they wanted was, if we've got a patient that's trouble up there, we want to know so that we can kind of keep an eye on them down here. It might tell us something about that person that we need to keep our eyes open, but that's not, we couldn't make that disclosure. Now, if they left the emergency room after security came and they had a baseball bat and they said, I'm going down the hill right now and I'm going to, break all the windows or I'm going to hit someone over the head, you could rely on Section 39 because they've got a baseball bat, they've left and they said that's where they're going, and it's reasonable that they may act on that. But it's a bit of a complicated section, but it is there. I tend to interpret FIPA as broadly as I can to allow for things to happen. So, the worst case scenario, if somebody files a complaint, they would file it with my office or they would file it with the Ombudsman's office. And if I can find a section in here to support you and to say that disclosure was appropriate, I will find what I can to help you. Because I don't think the legislative drafters, their intent in drafting this legislation was not to get in the way of health care. And I will never, ever suggest that, security should trump, or privacy should trump security rather. If you feel strongly that somebody's at risk, you need to do what you need to do. So those were the three questions I think that came my way, but does anybody have any other questions?
What are the limits around mailing patients things?
What we've said in our confidential information sharing policy is that Canada Post is considered secure. So you just need to be careful. Again, that policy gives guidance, making sure that you've put a return address on the envelope. That's where we have a lot of problems, to be honest. With inter-office mail and with regular mail, people address envelopes and they don't put a return address on it, and then it gets lost and nobody knows. When I'm investigating that or trying to figure out where that needs to go, who it needs to go back to, I have absolutely no idea. It's really problematic on the inter-office mail, on those envelopes. So what the policy says about inter-office mail is that if it's confidential and sensitive, you can use an inter-office mail envelope, but inside it should be in a secured envelope, a secure, sealed envelope, even for inter-office mail, because it gets lost all the time, and things wind up going from. It's an odd sort of thing. I know in Fredericton, for example, even things that are going from one floor to another, they leave the hospital, go down the street. Service New Brunswick, which is an outside organization, they sort mail and do their thing, and then it comes back. So even internal mail isn't really internal. It goes out and it bounces back in. So you have to be really careful using inter-office mail. Again, if a patient has requested that their information be mailed to them, or if that's normal practice, as long as you've addressed the envelope properly, you should be okay. But the confidential information sharing policy also talks about using discretion and making a decision about whether, for example, it needs to be tracked. In some cases, we had a physician who wasn't even a Horizon physician who was retiring, and she decided she was going to mail her 2 charts that she had in her office for her husband and a wife. She was going to send the charts to the physician that was taking over their care. And she came into the hospital and she put those in an inter-office mail envelope and sent them, and they got lost. So there's no copy of that. That's their original chart. It went missing. There's a happy end to that story, because about a year later, somebody was opening a box of photocopy paper, and for some reason, those 2 charts, they landed where they were supposed to, but they got misfiled, or somehow they wound up in a box, and somebody opened the box a year later and found these 2 charts. But if you're mailing the only chart, the original chart, it'd be wise to send that by courier, because at least then you've got tracking. If it goes missing, we have some idea of what might have happened or how to locate it.
Okay, now, I'm thinking we get sometimes compassionate supplies or chemo trials that have to be mailed to a patient.
Okay.
So we will use Purelator or whatever the best method of getting it to the patient.
Yeah,
So that's more what I'm
that
thinking.
sounds like it's fine.
Yeah, the patient usually is asked how they want it sent to them.
Yeah, that's good. Yeah, no, that should be fine. No problem with that. In pharmacy, do you have a lot of exposure? Like, are you directly involved with patients on a regular basis, or yeah, you are? Okay.
I struggle with that. We couldn't be involved in anybody's care, but we're not directly consultants. So as a clinical pharmacist, you technically could be responsible for everybody on your board, but nobody consults you. So determining if you're in the circle of care, I wonder if sometimes it's a bit difficult.
Well, again, that's why I don't like the term. So did everybody online hear that? Maybe not. I'm not even sure if I can really repeat your question, but basically what you're saying is that as a pharmacist, you might be responsible for a number of patients on the floor, but not consulted. And I'm not sure I really understand that. To answer it, I'm not sure I understand that. So can somebody help me a little bit more? Like, so you've got.
So if you're a pharmacist assigned to a patient board,
Yeah.
clinical area,
Yeah.
typically you would be responsible for providing personal care for any patients on that.
Okay. So you're not directly involved with the patient, but.
Yes, you could go see them at their bedside and ask them questions.
Yeah.
But and then there is cross coverage depending on if there's absence because of odd hours that we need to there's weekend coverage and things like that. So it's just wondering sometimes if it would be easy to figure out if a pharmacist is really involved in patient care.
Well, I think based on what you said at the beginning, I mean, you've basically been assigned to a floor, and that's enough for me. You know, like, again, if you're, the reason you're accessing, I mean, here's where a problem would arise. We do a random audit, and I look at the audit, and what's your name, Chantal? So Chantal shows up on an audit, and she's accessed Kelly Chase's health information. As long as you can explain your access, I mean, if it was really a question, because sometimes patients, and this gets really tricky for me too. All the patients, I've got a couple people that are a regular caller for me. Yeah, hi Kelly, I'd like you to run an audit. I want to know every single person that's accessed my chart over the last 12 months. And I don't like to do those audits, and I usually try to talk people out of those audits, or I try to at least narrow their request to try to figure out, like, what is it exactly that you're concerned about? Because there can be a lot of hands in a chart for a variety of reasons. And the problem with releasing an audit like that is then you've got a patient, and again, I'm going to pick on the mental health patients a bit because they're the ones that I'm getting the requests from oftentimes, and sometimes there's an issue around paranoia and whatnot, and they're worried, they think there's been breaches, or they think people are looking at their stuff, and then they see that audit and they see a bunch of names on it, and it's not their family doctor, it's some Chantal person's been in there, I don't know who they are, what were they doing in my chart? And so, you know, that puts me in a position where I have to go around then and try to make sure that all of these accesses were work-related. But if your access is a work-related access, that's not a breach. You know, you don't have to be necessarily directly involved. This is that whole section 18.1 where you're relying on the implied consent of the patient in the context of continuity of care. So, you know, any access in Horizon is role-based. So when someone starts a job at Horizon, they look at what your position is, what your role is, and they would have a role defined for pharmacists, and they would say pharmacists require access to A, B, C, D, E, F, G, and that's what they get. And then you take your privacy education, and through those 4 modules, you learn that you should only be accessing the information that you need to do your work. And if what you're looking at or what you're doing is directly related to your role and your work, there's no privacy. There's no privacy issue.
So with that question, if I was to follow up on patients that I'm no longer following, so I'm covering Chantal's unit this weekend, and I see patient A, I make recommendations, and I send Chantel an email saying, this is what I did, here's your follow-up, that, that should be done.
Yeah.
I would like to know for my own self,
Yeah.
how did my recommendations turn out?
Yeah.
So that I can find out for my own learning, did I make a good recommendation or not? Can I look at that patient's chart
I would say
a week
yes.
later to see what's
Yeah.
going on?
Now, so timing has sort of something to do with that, because if you're trying to say if an audit happens and your access happened 12 months after you were involved in their care, we might kind of wonder about that. But I've given the same advice. Emergency physicians will ask that. Emergency docs will ask that same question, because what happens is, they're on call, they're in emerge on Saturday, and a patient comes in and they discharge them home, or they say you don't need to be admitted, or whatever, they send them off. And then they might want to follow up. And maybe that patient, after they went off their shift, came back in and was admitted. Maybe that patient died. So that's a different section in the legislation, but that has to do with risk management and error management, and so following up to make sure that something didn't go wrong, or that the advice you gave was the right advice, that's all acceptable. Yeah, you would need to do that, and I totally can understand. Technically speaking, an emergency physician, after they go home and their shift's over and someone else takes over, they're not technically, that's why I don't like that term, circle of care. They're not actively treating that patient, but they were involved in the treatment of that patient and for their own follow-up to make sure that nothing bad happened. And with you folks, if you've given a medication and there's been an adverse reaction, or you would want and need to know that. So that's totally acceptable. Again, some of it's got to do with timing. The circle of care, we had, some of you may remember in St. John, there was a mental health patient, Serena, can't think of her name, the patient. It was in the news, which is why I'm saying her name, because this was a well-known publicized case. But I think it was a murder, if I'm not mistaken. I think she got out of the psych ward and they found her in one of the theaters or something. And I think another mental health patient had been involved somehow in her death. But anyway, that would have been one of those situations where we ran an audit, because there was lots of interest, and unfortunately lots of people decided to take a look after the fact to see what had happened. And one of them was a physician that had treated this patient as a child, as a pediatrician. Well, he tried to say I was involved in a circle of care, I was a treating physician, but that was when she was 5. She was in her 20s. You're not part of their circle of care anymore when you treated them as a pediatrician and now they're an adult. So that argument is not an acceptable reason for going into their chart. He was just nosy and wanted to know what happened.
I don't know if you can hear me.
Yeah.
Oh, okay. This is Marlene from St. John. I just had one question, just following up on the education part about the process with case presentations. These are commonly done as part of education to a broader group, sort of like the grand rounds that we have for pharmacy, like these sit-down grand rounds. They're sort of, we often use case presentations as a the patient's names aren't mentioned, but there's going to be a lot of information that's shared. Also, medical grand rounds is the same way. I guess I'm just curious, should we be handling those differently? Should we be getting patient consent for those as well? Because I don't think we've been doing that.
No, and that's what I've suggested, and that's what Doug asked me to consult on. He prepared a consent, and I think it might be being used in Moncton right now, but it's basically, or you can speak to it, Doug.
Okay. So from that context, I guess when you guys were talking about that a little bit earlier, I felt like it was more from wasn't talking about the case presentation piece, but we should probably consider that the same.
I think so. At the moment, I think that you have to consider that the same. A patient would not necessarily contemplate when they come in for care that their case is going to be discussed for education purposes. So it does.
That probably goes a little bit further than just pharmacy grand rounds, because in the medical world as well, medical schools, that's huge as well.
No,
so have you had that question from them, Kelly?
No, I haven't. And but the thing is, I should have mentioned probably when I was talking about this initially the legislation, I don't know I do know why they made the change, but you don't care why they made the change. So initially the legislation allowed for sharing of information for education purposes with employees. They changed it and they took employees out and said that you cannot use patient information for the education of employees without consent. It's presented all kinds of problems, and recently I'm part of what I call a CPO working group, and we just put this group together ourselves, but it's myself for Horizon, the Chief Privacy Officer for Department of Health, NB Health Council, Ambulance New Brunswick, Telete Health Network, and Service New Brunswick. And we have a weekly call. And one of the things we met about recently in person in Fredericton was there were a number of things in this legislation that are not working and that we don't like and that we would like to see changed. One of the things on our list that we've asked to have changed is that section. We'd like to have it go back to the way it was, which would include employees in the definition of agent, which would then allow us to share without consent for educational purposes. Right now, because they made that really odd change, and what they were trying to fix one problem and they just created a whole bunch of others. So by making the change, they fixed the problem they wanted to fix, but they caused a whole lot of other problems they weren't looking at the big picture is really what happened. So until that gets changed back, we are in this weird sort of gray zone. Because right now, my interpretation of the legislation is that we cannot share identifiable patient information for education purposes, and we have to be really careful about what we say is identifiable. And I tried to give you a bunch of examples, because if you can figure out who it is, some of you from Moncton would be aware several years ago there was a patient, there was a major breach in this Moncton hospital with a patient who had something inserted into their body and a bunch of x-rays, and people started looking. And it was a unique case. The patient's name wasn't mentioned, but this is before I came here, but I was involved. I was with Service New Brunswick, and Service New Brunswick needed to assist in the investigation, and there were a number of Horizon employees who did not know the patient's name, but were able to figure it out and go into PACS and look at this very interesting photograph of something, a foreign body that had been inserted into this patient's body, and it was a huge breach. So that's another example of where, nobody said anybody's name, but as soon as you know, we've got a patient right now that has something, has a wonky x-ray, everybody is interested in seeing what that's about, and people were taking screenshots, they were sharing them with the fire department over in Riverview, like that picture, and that's a huge invasion of that patient's privacy. Without ever using his name, even sharing that picture, because for one thing, this all happened in the first instance as a result of a violent act that happened to him, and secondly, you've got everybody in the hospital talking about this patient. And so again, you don't know his name, but it's identifiable because it's unique. So sometimes the question to ask yourself is, would the patient realize it's them? I heard that one time in the context of an x-ray. So somebody had a very unusual break, and most people would not have been able to look at that x-ray and know who it was, but the patient, when they saw the x-ray, they knew it was their x-ray. If the patient can identify themselves, it's identifiable, if that helps. So that's where we're at.
It's Heather.
Yeah.
I have 1:05 now, so we're going to have to wrap things up. But if anybody else has any questions, maybe I'll get them to send you an email to follow up, or if they can send them to me and I'll forward it to you. But
Absolutely. Yeah.
But thank you so much for a great presentation.
Okay, no, you're welcome. I'm right in the building. My office is located down, if you know where Risk is, and patient rep and that whole area. Well, actually, patient rep just moved, but I'm in that area where Risk is, the nursing services area. So my office is down there. If anybody has any questions, you can send me an email for sure. Okay? Okay. Thank you.
I'll just ask a quick question.
Yeah,
I can
sure.
see if I get